Well, hello and welcome to today's webinar, Advancing Interoperability in Healthcare During COVID-19. I'm Carol Flagg of Answers Media Network. Thanks for joining us on our continuing series of events with eFax Corporate. This event is brought to you by eFax Corporate and Consensus, a brand under J2 Cloud Services. For more information about Consensus, please visit the website www.consensus.com. The Consensus Interoperability Platform's patient records query through Care Equality is free during the COVID-19 pandemic. And now I'd like to introduce our two speakers for today's event. John Nebergall is the Senior Vice President and General Manager of J2 Cloud Services. John is a seasoned veteran in the health IT space with over 30 years of experience. Before joining J2, he held several senior level positions at Orion Health, Experience, and Demand Force. He's an adjunct professor of clinical informatics at the University of Illinois, Chicago, and is also a certified CPA, earning his undergraduate degree from DePaul University and his MBA from the University of Chicago. Joining John today is Scott Stewie, President and CEO of Direct Trust. A 25-plus year health IT veteran himself, his role at Direct Trust is to drive visibility and utilization of the Direct standard to contribute and further nationwide interoperability for the healthcare industry. Under his tenure, Direct Trust reached 1 billion direct secure messages sent and received over the Direct Trust network. Prior to Direct Trust, Scott held senior positions at Datafile Technologies and at Cerner, where he led that company's participation in the Commonwealth Health Alliance and the bridge with Care Equality. And now I'll turn the presentation over to John and Scott. We will leave time at the end to answer questions, so please feel free to use the question tool on the GoToWebinar dashboard.
Thank you so much, Carol. I appreciate it. And I think that as we look at COVID and what it really exposed in the health system infrastructure over the course of how this pandemic unfolded. Front and center is the impact of the real lack of interoperability on being able to effectively respond to the pandemic. And really what I'm thinking about here is the clinical information that is so vital to be able to treat patients became at very much a premium as COVID unfolded. When you think about where clinical information needs to be at the point of care and the difficulty during COVID we have at getting that at the point of care, it's really amplified when you think about the number of people who would show up at an urgent care center rather than their own physician. Would go to these mobile testing centers that are all over the country instead of going to a doctor's office or a clinic. And the need for that information to become available not only to that patient's own primary care physician, but also to public health entities, to the large community that requires information on how to treat these patients, how to understand which patients have comorbidities that could affect the way that and the aggressiveness of the treatment, and even down the line as things start to return to normal. As these patients go back to their regular physicians, as elective surgery starts again, the information that is so vital to be in that patient's record is very often, as we're seeing because of the lack of interoperability, not immediately available to be able to offer the best information to the provider at the point of care. Go on.
Yeah, so I think in terms of understanding interoperability generally, and so this is Scott, by the way, and really glad to be here with you. There are really kind of pathways or components of the problem of interoperability that are worth discussing. Kind of at the very start of any kind of healthcare information exchange is security and privacy. So questions about whether or not the data is actually secured is especially important with healthcare data that is sensitive by its nature, but also when you're talking about something that may have a stigma attached to it, like a COVID-19 diagnosis. The security and privacy of data is paramount. So being able to know that your solutions are connected and usable. Usability is an area that has continued to kind of plague the healthcare industry, and a big part of the usability issue relates to those what I'd call interoperable workflows, the kinds of the places where you'd see the data interacting with outside systems. Those workflows are frequently the ones that are relatively new in terms of their adoption, and as a consequence, they haven't as much time to mature. And so making those systems capabilities efficient and usable is really important. Otherwise, frankly, people don't even care about the data if they can't use it. So making sure that it's a cost-effective approach that doesn't create a burden on the organization. And in the COVID realm, we're seeing that frequently when new needs are emerging, it's really difficult for organizations to come up with new sources of revenue to cover those new needs for infrastructure. If, for instance, there's a need to now send information to parties that have not typically been trading partners of an organization, it can be a burden unless the technologies in use are easy to use and easy to advance and implement. So the way in which a lot of that is enabled is through the use of standards. So I think people understand standards in a variety of ways. I mean, if you think about standards in the building industry, for example, the fact that everybody's concrete blocks look the same means that you can build a building from concrete blocks that are from two different manufacturers, and your building will not look strange. So that's an important element. But when you're talking about healthcare interoperability, standards that work really relate to the usability question in part, but also in terms of the cost effectiveness. If you've got a standards-based approach versus one that's proprietary, then implementation costs are lower, and also there are just fewer moving parts. There's less time trying to figure out how to transform transactions that start one way and need to end up another way. That's why standards are so very valuable. So there's also a need inside of healthcare today. There's a need to connect beyond the systems that are electronic health record systems. And that is an area in which the direct network really shines. That the challenge is here when interoperability is thought of, it's can I push button A in system 1 and have that same button pushed in system 2? Well, if system 2 doesn't have a system at all, really it's just literally like a homeless shelter or something like that, how do I make that connection to an organization that doesn't really have a system? So that doing that in a way that is standards-based and still secure and private is actually a really important way of thinking about the interoperability problem that we're having under COVID, with all of the organizations that got stood up so fast and with no previous experience as environments, like a laboratory testing center in a parking lot, for example. These kinds of things that happened during this COVID disaster have been, frankly, a real challenge for folks, and those kinds of circumstances make it pretty more easily done with technologies that are standards-based, that are cost-effective, and don't require a lot of orchestration to implement. And then the last thing is, frankly, we got to learn from each other. One of the things I like to say in the direct trust community is, if only everyone can do what anyone can do, that would make everyone better. So I think that is what we mean by shared best practices. But the benefit of that is then you can find out what people what people are succeeding with and how. So That's what I would think is most important about understanding, the interoperability componentry. The next slide.
Yeah, thanks. When I think about the larger end goal of interoperability, I think you also have to think about the breadth of a patient's journey through the healthcare system. At the point of care at any particular time, especially if it's an acute event or something very specific, there's some amount of data that is immediately helpful. But when you think about the larger picture as well, the depth of data and the information that is accumulated on a patient over the course of their lifetime winds up being vitally important as especially as we get older and the overall history of what our patient experience has been is more and more important to think about how treatment and plans need to unfold. So when you think about interoperability, it's not just about the data that I need right now for this event, but it's also about being able to accumulate this data in a real longitudinal record for the individual patient. And as we think about the different episodes of care and using COVID as a good example, I think that the explosion of telehealth and the experience that most people have with telehealth. Myself, I've had a consultation with a telehealth provider that was assigned to me essentially through my payer, and it not my regular doctor, not my regular PCP, and while the encounter was great, where does that information go, and how does that information get back to my PCP and incorporated into the larger picture of my own healthcare journey? Being able to integrate that data, the data that any kind of visit like that, or an urgent care encounter, or again, as we both mentioned, these testing facilities that are popping up in parking lots. How do we ensure that gets to where it needs to be, and that we are able to take a holistic view of the patient at those points in our care journey where that holistic view is vitally important to understand the right care plan for an individual at a particular point in time. The other piece of being able to accumulate this is the ability for it to go into a larger set of knowledge, right? For research, population health is counting on being able to gather as much of this information as possible to be able to see trends, to be able to react as you need to in the case of epidemic, pandemics, or regional outbreaks. And those kinds of things, whether it's COVID or if it's some other kind of event or disease, need to be able to be brought together in a meaningful way, in a structured way, in a way that allows researchers, population health experts, departments of health across the country to make sense of it. So I think that more than anything else, the current environment has raised the visibility importance and frankly, the gap we have between where we are and where we need to be in being able to exchange information, be able to accumulate that information in a meaningful way, and be able to apply that information to the particular point of the journey of the patient at the point in time where it's going to be necessary in order to understand what the next step is.
Yeah, so let's talk a little bit about the regulatory circumstance now. Next slide for us, please. Thanks. So the big thing here is that starting in 2016, there was a pretty substantial change in the regulatory environment. The 21st Century Cures Act, which was signed by President Obama at the tail end of 2016 and was absolutely a bipartisan piece of legislation, had really a lot of things in it, but a big piece of it was the interoperability space, and it brought to the fore several kind of key elements. The biggest are sort of listed here on this page, but first, I guess, to keep aware of, I think the focus of this ONC, of this national coordinator, Don Rucker, and of the ONC in general has been to focus on patient right to access, the patient's right to their own record and the ability to get a hold of that through a mechanism that would be more modern and more more easily deployed and more easy for consumers to get hold of. So supporting standardized application programming interfaces, or APIs, allowing basically not just supporting them, but mandating their deployment by provider organizations. That was a big component of of the regulatory framework that was passed as a part of the 21st Century Cures Act, and then later as a part of what's called has been called the Information Blocking Rule, which includes several elements. These first two certainly. Big piece of this application programming interface ecosystem that's imagined is the idea that there would be a choice of apps, and then that it basically encourages that individual consumers would be able to get access to their own records and curate them on an app of their own choosing and share them with whoever they see fit, which raises absolutely some questions about things, but these are kind of two of the key elements. And John, maybe you can talk about a couple of these other options.
Well, and thank you. I think that the CMS rule, it was interesting to read because they actually pointed out their disappointment in the inability of the industry to be able to solve this problem. They had put a number of incentives in place that should have been able to drive behavior in a certain direction, and the result was certainly less than stellar. Those incentives haven't worked, and it's needed to go to actual rulemaking to force people to do essentially the right thing, which is to not block information for competitive or whatever reasons, to be able to share that information in a way that is about being able to deliver better care to the patient. And I think that the transparency around patient safety is really driving this. And I think, as you mentioned, Scott, that this is very bipartisan. I think from administration to administration, if anything, I think I've seen each one become subsequently more aggressive about this particular issue. So it transcends party lines and really focuses us on what's important. How do we do the best things we can for the patient, regardless competition, regardless who thinks they own the data. I think CMS has made it very clear that the data is there for the patient's benefit. And since we're not seeing that data sharing as widespread as it needs to be, we're going into a directive phase where the government's done suggesting and incentivizing, but now it's telling. And those are the requirements that it feels it needs to put in place to get past the difficulty that the industry has had generally to be able to share that information, and in fact, some people even holding data hostage. The standards, FHIR.4, and care settings for sharing data are detailed out in the rule, and not only is this a direction that we've had to move to in order to advance interoperability, but it gets back to patient safety and transparency for patients to get access to their own data, which is really a big part of this rule. I think that the reality of being able of ensuring that we have electronic transmission also gets to the heart of how we are able to share that information in a very fast way, a very efficient way, in a way that starts to unclog the paper from the system and starts to make transitions very useful, events very, very useful in terms of their creation of information that is then required to be sent on when those events occur.
Yeah, and I think there's one more thing, one more regulatory element here that is interesting. In the CMS rule, there was this requirement around the sharing of ADT information electronically. Now, this is specific to the hospital. The requirement is actually on the hospital. So what's interesting is, as we in Direct Trust have worked with the electronic health record vendors in an organization we're calling the EHR Roundtable, they have come to the conclusion that some standards work is needed in order for direct messaging to work effectively for ADT communication, because basically this ADT ecosystem that's in place today is widely variable. There are many hospitals that do share ADT information today. By many, I mean a large handful, I guess, is probably the right way to describe it. Nowhere near all of the 5,500 hospitals in the U.S. do that, and the obligation under the rule is actually for hospitals, psychiatric hospitals, and critical access hospitals. It's a broad expectation, and the concern that is coming up in the EHR market is that the receivers won't be tuned up ready to receive this information. A lot has been made of sending information or getting information from point A to point B, but sometimes if they're not caring about how things are going to work in system B, then you create burden for the user, and that that usability we talked about earlier can be an issue. I don't know whether you've seen some of that too, John.
Yeah, and in thinking about that, building on that, Scott, it really is about needing to understand the receiver's point of view, the sender, and there's been direct is certainly one of the technologies called out in the rule, as well as FHIR, to be able to send these electronically. The question is, what does the receiver have? And especially when you get into post-acute facilities that have, in many cases, not been terribly well funded or are ready to have an EHR type of system available to consume these. How do you get that message out? And how do you make it usable? From what I've seen, you have episodes where the information for that episode can get into somebody's hands. Let's even say it's something that is done on paper. But then once that information is in somebody's hands, how is it able to be used on the go forward? So how to get it there meaningfully, how to make sure that the receiver can use it. These are huge questions, and especially as we start to think about where these receivers are in terms of the continuum of care, you start to also see some disparities in that receiver's ability to do meaningful things with an electronic transmission. That's why flexibility and a knowledge and understanding of what is on the receiving end is important for each hospital, and that gets to be a very tough situation. So as you think of the resources and options that are out there for interoperability, a lot of this stuff isn't new. And point-to-point transmission to the ADT question that we just talked about, this idea of one facility to one facility, or one physician to another physician or facility, is probably the easiest way to think about interoperability communication, provider to provider. So that has an easy way of being able to be executed. And frankly, I think everybody's point of view is that in healthcare, about 75% of that uses fax protocol for a transmission. Now, CMS has really detailed the need to use API integration for sharing data. And API integration is a powerful tool. You know, it allows one system to speak to another. You know, two EHRs can talk to each other, and it also gives the vendor community real guidance on how to structure a transmission in a way that is most useful to both the sender and the receiver. And you know, frankly, it opens up the door for the vendor community to think about applications that are made for data sharing, and not only between providers. Clearly, patients are in that mix as well, and in fact, CMS is very much pushing the industry towards ensuring that information, and not just information from the clinical encounters themselves, but also from the payers, is immediately available to that patient, and being able to create apps and ways for that patient to easily get that information to themselves is opening up a lot of potential doors for development, for progress, for thinking about things in terms of ease of use that really were backburnered before, but now are at the forefront. So standards have to be created in order for all of that to work. And to Scott's point, without standards, you wind up with data that can't be synthesized into information, and it's certainly been a roadblock. I think FHIR.4 is going to play a big role in reducing that. You know, direct secure messaging is really the fastest growing method for sending documents between providers. You're eating into traditional kinds of technologies. I think you've probably got what north of 2.5 million direct addresses now, closing in on 3 million direct addresses. So it's certainly widespread and ubiquitous. But as we've seen, the tendency to use legacy fax because it's convenient, it's a known quantity, it's you know, frankly, it's a machine that's in most every provider's office, is still out there and still being used a great majority of the time. And the consequence of that has also been demonstrated. I know that you've probably seen articles that have shown up in the newspapers, even the New York Times, about how this information, when it gets to where it's going on a piece of paper, is starting to stack up. There was a piece about the public health department in Texas that was 10, 12, 14 days behind in being able to record test results from COVID tests that were being administered in order to track these for population health purposes. and they just had stacks of paper that had come off fax machines that had not yet been entered into a system, and we're just waiting for that. And this information is vital to be up to date. Now, digital faxing, cloud faxing can give you advantages from having it be an electronic workflow, and certainly can add to the speed with which those things can be rendered into usable data. And relative to paper fax is certainly a huge leap forward that can be implemented without changing workflows around it, or without the substantial cost or new learnings for the folks on either end, either the sender or receiver, to be able to integrate into their own process. So while all of those are out there, the overarching thought, though, has to be, how do I make sure that when I have these episodes or point-to-point kinds of communications, that I structure them in such a way that they are usable data that can be become part of a patient's longitudinal record, or a research database, or a population health information set that can benefit the patient and society as a whole, and not just lost as a single piece of information used by one provider one time and then moving on.
Yeah, so let me drill down a little bit on direct secure messaging for a second. So one thing I think that's interesting about direct, go to the next slide if you would. There is I think one of the interesting things about direct secure messaging is that an awful lot of folks who have it don't even know they do. It's actually very widely deployed. It's basically in every certified EHR system in the country. So we're talking about literally hundreds of thousands of organizations, millions of individuals able to do this. And yet the fact of the matter is that a whole lot of the folks that have access to this tool don't know they do, and as a consequence, they're falling back to their legacy fax because they know that in much the same way as knowing a fax number, knowing a direct address for a business partner is no more difficult, and yet it seems as though it has struggled to take off, and yet we haven't been at it that long. So the one thing I want to make sure people understand, direct secure messaging was developed to be a secure and simple transport mechanism for sensitive information. That I think it has achieved that, but it has been in place for less than 10 years. So it takes a long time to get things like this to become ubiquitous. Now, if you look at e-prescribing, for example, we've been at that for 20 years, and we're at 80% or so of prescriptions being sent electronically today. But that took 20 years, and it took a lot of attention by the industry and government pushing that along and continuing to incent it and its use. So it takes a while to get these things to take. A little bit more about how it works, though. Direct secure messaging is a secure mechanism because it uses a PKI framework, which means that digital certificates, which are identity assured, in other words, the individuals on both sides of the transaction are identity proofed, and so the sender knows the receiver's identity before sending the message, and in fact the system won't send the message unless the address is trusted. In other words, that address has to be a part of that set of identity assured addresses, or no transactions can flow. It uses a standard that was developed over that same 10 years, the direct standard, that was work that was done by an organization called the Direct Project, that over time Direct Trust took over for the Direct Project. A little bit more about Direct Trust on the next slide. But so the need to serve as a cornerstone for facilitating interoperability with disparate health technologies, it's particularly good, as I said earlier, in dealing with connections to organizations that have nothing, nothing in the way of a system or little in the way of a system, or a system that is not a certified system, for example. The EHR systems may treat this as a sort of a background process that is very, that users may not be aware of, where when it's implemented in some systems, it literally looks like an email, although it is not email. It is secure and identity assured in the way that email is not. So it's unique that way. And in the EHR systems, it doesn't even necessarily look like email. It looks like referrals and inbound messaging, but not necessarily like email. So that, I think it's important to understand. If you are a user of a system and you don't think you have direct secure messaging, I'll bet you do. You may just not know what it's called. So do a little digging, and you may discover you have the ability to replace a lot of the transactions you may be sending by legacy fax through direct secure messaging. So go to the next slide for me, if you would, and I'll finish up a little bit on direct trust. So direct trust as an organization has came into being because the direct standard all by itself is the security that I described. That sort of secure framework is required. But what was present in the early days before direct trust was this need for all of the operators of the network to have separate agreements between each other. So they had to have, which made it really, really hard. There was no network per se. There were lots of networks that all talked to each other. And so what direct trust did was it created a sort of a network of networks, and then built what they call the trust bundle, which is basically a set of certificates that can communicate with each other, or that allow for direct trust messages to be communicated with each other. There are now 2.42 million trusted direct addresses and 240,000 organizations that are served by this. We're now, over 141 million messages sent and received in last quarter. Now that was actually down because of COVID. So COVID-19 has had an impact on encounters, which has had an impact on all transactions, as you might imagine. Although interestingly, we've seen in this last quarter, and our new metrics aren't out yet, so I can't share those with you just yet. But what we've learned is that now there's an awful lot of our HISPs, these organizations that operate the direct trust network, that are seeing transactions that are flowing for COVID-specific purposes, notifications purposes, reporting what they call initial case reporting results to public health systems. That flow has created a bit of a lot of transactions are occurring in that space that are kind of filling the gap between what used to happen in the way of just routine referrals that frankly are way off now in the COVID-19 realm. So that's really interesting to see. We are at this kind of remarkable 1.5 billion cumulative messages sent and received in those 7 or so years that the network has been active. And when I tell you that this has been tremendously gratifying to see grow, so pay attention in the next week as we announce our new metrics. And also, there's a couple of things that we're doing. I want to make sure that people understand. We're a standards body, and we're also a membership organization. Our members are getting together to do some work in this notification space that I described earlier. I think that everyone will find that very interesting. We're doing that in our ANSI accredited standards body so that we can get all the constituencies that need to be involved in that conversation and bring them together to collaborate to create a standard that will be usable for the entire market and solve the problem for the receivers as well as the senders, because there's a challenge for that. So eager to see that shake out, but we really believe that direct has a huge role to play. FHIR has a huge role to play as well. I think for referrals, for transitions of care, for anything that is iterative and communicative, direct secure messaging is the preferred modality over all other alternatives at this point in time.
And building on that, direct has made fabulous inroads over the past several years as being a very reliable, a very widely used method of being able to share information. I think that as a cornerstone of what we had thought about in creating a platform that can facilitate a wide variety of communications, at a center pillar of that was the incorporation of direct. As you think about the wide variety of ways that people communicate patient information, that really brought us to the conclusion that a platform that could accommodate a number of these kinds of interactions was essential to be brought forward into healthcare and start to solve some of the problems of, I'm communicating, I'm sending a message a certain way. I need to understand or know if the receiver can receive it. Using a platform approach like Consensus, we really wanted to think about this in terms of being able to facilitate the exchange in a HIPAA compliant and secure environment that started to take some of the guesswork out of the conundrum that a sender may have about how do I get something from here to there. So being able to share information, whether I'm using fax protocol or direct protocol, whether I want to use Commonwealth or Care Equality to query a patient record, and to be able to put some tools around that to help manage that flow of information once it's received so that I can get it into my EHR or other electronic filing system. And I think as you think about the many points of care that don't necessarily have an EHR, you start to realize that access to some kind of inexpensive, easy way of communication absolutely enhances the ability for somebody to allow better care to that patient, especially in transitions. Now, in order to help Scott out, what we've done in this is to also be able to cross-reference. So, as Scott mentioned, some people know the fax number off the top of their head, but don't necessarily think of a secure direct address the same way. Inside this platform, we were actually matrixed the two into a cross-reference table. So a fax number that's associated with a direct address that we know of and that we've sent to either through the collective information that we're getting through our HISP or from Consensus, which is constantly learning as it goes through the process of facilitating information. It'll actually cue the user that, hey, by the way, while you're dialing up this fax, you could send this as a direct message, and give them the opportunity to be able to do that. It also allows for an electronic workflow on the receiver end of things to very easily break a fax up into its component parts so that it can quickly put that documentation and file it into patient records. And in fact, if there are certain rules that are always followed with certain kinds of documents being received, it can just apply those rules and automatically file it. So we wanted to facilitate communication. We wanted to facilitate electronic filing. We wanted to alert the user when there was a superior way to send the information across the network. And we wanted to put that into a package that was very secure and didn't necessarily need an EHR, but could be used as a standalone web-based interface so that the user, whether they had an EHR or not, could participate in an electronic communication. And on the next slide, there are a couple of use cases for to talk about how this would look like in real life. So if you think about a discharge from a hospital to a post-acute facility, and the information that needs to flow not even to that facility, right? Because the patient journey is going to go from the acute care center to the SNF, back to their home, and ultimately have to be in the hands of their PCP. Being able to ensure that in that use case, from point to point to point, even though the method of the receiver for getting information may change, the ability to use a single approach to ensure that information goes from point to point to point, and make sure that patient's information is not lost at some point of a transaction, but able to be incorporated into a longitudinal care record for that patient is really as you thought about consensus, as we conceptualized it, this is probably the classic use case. I think that we've also thought of the use case, for example, of a physician practice, especially as you get into an older patient that may see multiple specialists, or a patient that may have comorbidities, to be able to ensure that communication from that physician to a variety of places, again, may or may not have an EHR, may or may not have a direct address, but still needs to be able to access that information in order to ensure quality care for the patient, that we would be able to take the uncertainty out of that transaction by being able to facilitate the wide range of potential ways that you can communicate, and to be able to do that again in a secure platform that is inexpensive and doesn't require an EHR. So that was really the thinking behind what we wanted to bring to market.
All right, so we've got some time. We've got about 10 minutes here for some questions from the audience. John and Scott, if you can stick around, we'll go ahead and take some.
Love to do it. Thanks.
Great.
Yeah, why not?
And just to remind the audience to use the question tool on the GoToWebinar dashboard. And if we don't get to all of your questions today, which I don't think we will, but we will get back to you and answer them offline. All right, so first, CMS doesn't say how the ADT electronic notification should be sent using what protocol. Can a hospital use cloud faxing to send the information? And what about mobile text messages that's so in practice today?
Let me take this first. It's interesting. I agree with the questioner here that CMS doesn't say really a lot. The rule is actually quite vague, and for better, I mean, some folks would say that's good, that that they haven't been so prescriptive. People have used that prescriptive word, the P word, as though it's all a bad thing. It's a little bit of a challenge that when something is not prescriptive, it's not really clear what will or won't be possible. I think that people will try lots of things. The question will be whether people feel confident reflecting that they've covered the actual requirements of the rule, which again really aren't very specific. There's no specific protocol or requirements about that. So I do agree with the questioner's intimation here. I don't know, John, what your thoughts about whether or not you have thought through whether cloud faxing or text messaging might satisfy it. I'm not sure that it would or wouldn't. I'm interested in your attitude.
Well, so I'm as I thought about the rule, I kind of saw this as a CMS first step, the walk before you can run kind of thought process. So what we do know is that you need to notify and you need to do it electronically. Now those are two big steps forward. would cloud fax satisfy that, based on the kind of wide guidance? It certainly would, and it would be a way to electronically file that information. Frankly, direct would be a more flexible way from a use standpoint for somebody to send it from the discharging facility to the end user provider that needs to receive it. And probably the most flexible of all of them would be an EDI transaction using FHIR that EHR speaks to EHR. But all three of them require that an adoption of electronic means to send this from point A to point B, to do it securely, and starts to, I think, encourage people in a way that wasn't there before to adopt electronic workflows. But the hardest thing in my mind about the adoption of modern electronic interoperability tools has really not been the transmission, but the embedded workflows in different organizations about how these kinds of pieces of information are handled. And, I've personally had the experience of watching an implementation of cloud fax where the fax machine is taken out of the workflow, and that actually disrupts the user, because they are used to starting their workflow. The call to action was always a piece of paper comes off this machine, and then I do X, Y, and Z. Now, without the piece of paper coming off the machine, you actually had to re-engineer the workflow, and that's hard. What CMS is doing here is saying, look, you've got to re-engineer your workflows to an electronic transaction, and you need to do that in order to be in compliance. Now, I think that's the walk before you run, because the adoption of that starts to open doors in terms of being more prescriptive with the kind of electronic transfer that you're putting in place. But it does force, I think, the hardest part of it, which is new workflows based on an electronic communication that need to be incorporated into the way that you handle this information.
All right, so as not surprising we got this question, as the pandemic is not waning and will worsen during the cold and flu season well before a widespread vaccine, any thoughts on whether there may be further implementation delays of the rule?
Talking about the
further implementation
of the rule.
I didn't hear the last word.
Yeah, further implementation delays. The questioner is asking if there'll be any further delays if the pandemic does not wane.
Oh, in the new rule. Got it.
Yeah.
Got it.
Yeah. So I think, so some folks are asking for that. Let's just say that. So this last week there was a survey. I don't know, John, if you took that or if you got it in your inbox, but the Electronic Health Initiative, eHealth Initiative, I guess is technically what they're called. The eHealth Initiative sent out a message saying, hey, do you think we should delay the, it was actually specifically the CMS rule, I believe, that they were talking about, not so much the information blocking rule, but the CMS rule that includes the ADT requirements. So they were asking if May is too fast, too soon, and I think that I have a lot of friends in the electronic health record industry. I think they would say it's moving pretty fast. It's for them to make any kind of changes of substance, but I don't know whether they'll respond to those requests or not. Will we? Who knows? That's my question, my answer to that question. But should we? Perhaps. I mean, I don't. I'm not. It definitely is an aggressive time frame, and particularly since it didn't have a lot of. What I've got to tell you is that people are only just now figuring out. I got to figure out how to do this, and they've actually, in theory, kind of wasted 6 months. Because they just now got around to thinking about it. It's been out there in the rule for a while, but now folks are just now starting to work on it. I don't know if you agree with that, John, or not.
You know what? I think that these kinds of questions, you know, from CMS or ONC are always a slippery slope, because as soon as you start indicating that you're willing to let things slip for one reason or another, it becomes more and more difficult to dig your heels in at some point, because you've already started down the path of loosening things up. Now, that being said, I think that the pandemic has really exposed the difficulty that providers have because of the lack of interoperability. So the fact that, you know, interoperability hasn't advanced through incentives, and the hope was that it would, have put us in a situation where sharing information right now when you need it most has become an impediment to delivering proper care to a patient. I think that there is a school of thought that says, you know, once you're in the middle of the hurricane, it's the wrong time to start boarding up your house. If you miss that boat, you miss the boat.
Yeah.
So I could see the logic in saying, look, because of this extraordinary event, we have to forego kind of imposing the rules right now. But I wouldn't want that to turn into something that remained any open-ended, because I think you really do have to dig in your heels at some point and say, look, you know, we can't afford to have another event happen and for us to be caught in the same situation that we're caught in today.
Yeah, good point. COVID-19 aside, any challenges being uncovered with vendors and insurers bringing API solutions to market?
You know, I got to tell you that I have some visibility to this, just again, because of the relationships that we have with the HR market.
Sure.
I can't speak to the payers as much as I can to the HR market, just because I don't really have visibility to their work, to their development work. The good news that for them is that this is new to them. These obligations are new to them, right? Where the HR companies have been responding to the certification rule for quite some time. But here's the fact about EHRs. EHR companies have only so much capacity to do development, and their roadmaps are dominated by regulatory requirements, particularly when a big new rule drops, like information blocking. So the information blocking rule has this brand new requirement for them around a patient right to access through an app of their choosing through APIs. A lot of them had a lot of that work done, and they also had some other work done in the FHIR space. But there's some other new things that were introduced, some obligations that they had to build new capabilities that they don't have anything for at all. Bulk transfer capabilities between EHRs, for example, for the purposes of closing down this EHR and getting this one up. That idea is a brand new idea, and nobody has any software for it. So they have to build that stuff from scratch. So what I can tell you is, when it comes to FHIR, FHIR at this point in time, there's really kind of no way to hype FHIR more than it is hyped now. We're at the peak of the hype cycle in FHIR. I think from here we're going to see a little bit of cooling of FHIR, because it's just not possible for the EHR companies to build it at the rate that people can write implementation guides. So it's possible to create a new capability on paper, but then to put that into software requires, it goes on a roadmap and it gets developed and it gets deployed in client bases. From experience, we know it took 20 years for e-prescribing. We're 10 years into direct and we're nowhere near done. It'll be 10 years for FHIR, and we're less than 2 years into FHIR. So I don't think, is there going to be, to me, it's not a challenge, it's just a fact. It's just going to take a while.
We're just about out of time for our hour. So I'm going to take one more question, and that is, who within a healthcare organization will likely bear the responsibility for compliance and information blocking requirements?
Well, I think that's probably shared because, you know, I don't know your feelings, Scott, but if you're looking at a specific HCO and you're thinking about what your policy is and how you structure it, you'd almost need to have, you know, several internal stakeholders, and you'd also have to have several external stakeholders, the folks that you regularly exchange or share this information with, right? The community at large. So, you know, in addition to, you know, the obvious folks like your administrators, CTO, CMIO, you probably also need to reach out to, you know, facilities that you would generally be sending these notices to, the local community of primary care providers. It would have to be, I think, broader than the four walls of the HCO itself.
Got it.
You know, I agree, John. I think actually the question, it sort of answers the question for itself, which is who's responsible for compliance? Well, compliance is responsible. What I've heard from like when you participate in the information blocking work group at Care Quality, that's actually kind of what their recommendation was, and what a lot of organizations' recommendations have been, which is make this a part of your overall compliance effort, because it, frankly, give it to the same people who also have the disparate job of, you know, managing compliance around billing and, you know, all of your compliance things are all over the facility, right? So many compliance with infection control regime, or compliance with, you know, billing requirements, or with, you know, MIPS and MACRA or whatever. I mean, all those things are pretty different from each other. So the fact that information blocking is different from all those things, I don't think will surprise the compliance department. They're used to handling lots of different fruits.
One more thing. John, Scott, I want to thank you so much for your time today, for a great presentation, your knowledge and your wisdom. I also want to thank the attendees for showing up today. We appreciate your time. A copy of this recording will be delivered out to you in the next couple of days. And until our next event, I hope everybody stays safe and healthy amidst the COVID pandemic. John, Scott, thank you again.